Możemy zaczynać? Esteemed jury, dear participants, listeners, ladies and gentlemen, on behalf of the Student Scientific Associate of Medical University of Silesia in Katowice, I would like to thank you for your coming and taking part in International Medical Congress of Silesia 2024. My name is Cornelia Korzand, and I have an honor of moderating and coordinating physiotherapy, orthopedics, and traumatology session. I would like to cordially welcome the esteemed jury, President of the jury, Associate Professor Renata Wilk, Medical University of Silesia Professor. Thank you. I would like to welcome warmly Dr. Violetta Ivanova, guest from Bulgaria, Assistant Professor at the Faculty of Medicine of Track University. And Dr. Vania Stefanova-Pavlova, guest from Bulgaria too, Chief Assistant at the Faculty of Medicine of Track University. We are pleased to be honored by the presence of the Provincial Coordinator of the National Council of Physiotherapists, Marcin Rutkowski, and Karolina Kucharczyk. Among members of the jury, I invite Associate Professor Małgorzata Dąbrowska-Galas, Dr. Dagmara Wasiuk-Zawada, Dr. Agata Dobrowolska, Dr. Paweł Niewiadomy, and Associate Professor Ryszard Tomaszewski. I cordially invite you to Marcin Rutkowski to introduce the letter from the President of the National Council of Physiotherapy, Dr. Tomasz Dybek.
Szanowna Pani Przewodnicząca, Szanowna Pani Koordynator Fizjoterapii, studentki i studenci, Szanowni Państwo, serdecznie dziękuję za zaproszenie do Katowic na konferencję zorganizowaną przez Studenckie Towarzystwo Naukowe Śląskiego Uniwersytetu Medycznego w Katowicach. Z dumą i z satysfakcją przyjąłem w imieniu Prezydium Krajowej Rady Fizjoterapeutów honorowy patronat nad tym wydarzeniem, które organizowane jest już od 7 dekad. Cieszę się, że studenci fizjoterapii także angażują się w rozwój naukowy, biorąc udział w sesji poświęconej fizjoterapii, ortopedii i traumatologii. Szczególnie istotne jest to, że obok obowiązków studenckich znajdują czas i mają odwagę, aby przedstawić wyniki swoich badań przed zasłużonymi profesorami i wybitnymi specjalistami medycyny. Chcę, abyście mieli świadomość, że Wasz wkład w rozwój nauki ma znaczenie nie tylko w kontekście własnej edukacji, ale także dla całego społeczeństwa, realnie wpływając na poprawę stanu zdrowia i jakości życia Polaków. Pragnę jednoznacznie podkreślić, że w obecnej kadencji samorządu zawodowego fizjoterapeutów szczególnie zależy nam na zwiększaniu renomy i profesjonalizacji zawodu poprzez działania służące rozpoznawalności i uznaniu naszej grupy zawodowej w strukturach ochrony zdrowia. Wspieranie pracy naukowej służącej rozwojowi polskiej fizjoterapii. Dzisiejsza konferencja wpisuje się doskonale w te priorytety. Wyrażam uznanie za włożony trud i za zaangażowanie w przygotowywanie przez wiele lat wspomnianej konferencji, która na trwałe wpisała się do kalendarza wydarzeń naukowych z dziedziny fizjoterapii. Wszystkim uczestnikom życzę zdobycia jak największego zasobu wiedzy, która służyć będzie poprawie ochrony zdrowia i jakości życia Polaków. Organizatorom dzisiejszego wydarzenia, gratulując konsekwencji w działaniu, życzę satysfakcji z wykonywanej pracy oraz realizacji zawodowych planów. Z wyrazami szacunku, prezes Krajowej Rady Fizjoterapeutów, dr Tomasz Dybek.
Thank you a lot, Mrs. Karina. Thank you. Okay, I'm sorry, przepraszam. I would like to invite you warmly. I'm sorry. Professor Virginia Likus, Professor Sum. Thank you. I'm sorry, thank you. We would like to explain to you the results of the rules of the session. The order of the presentation will be the same as in the abstract book. The maximal time for presentation is 7 minutes and 3 minutes for the discussion. If the presenter exceeds the time, he or she needs to move on the conclusion and finish the presentation as soon as possible. Esteemed jury, I would like to kindly remind you that if you are the supervisor of the paper which is presented, you should not assess the work. In that case, please cross out the number of your card. Other members of the same clinic are able to assess the presentation. The assessment will be verified. All the presentation and the discussion may be run in Polish as well as in English. I would like to remind that if the work is presented in English, the discussion also should be run in English. If the commission will ask the question in Polish, the authors of the work are allowed to answer in Polish. We kindly ask the jury to assess to grade on a scale from 1 to 5. Scientific value, way of presenting, discussion, and out contribution. When the session ends, we kindly ask to give the card backs to the coordinator. To begin, I think we can start with the first presentation by Miłosz Strugała, assessment of treatment methods for femoral neck fractures and the Department of Orthopedics of SIMC Katowice.
Good morning, ladies and gentlemen. My name is Miłosz Strugała, and I am honored to present you our work entitled Assessment of Treatment Methods for Femoral Neck Fractures at the Department of Orthopedics of Silesian Medical University in Katowice. To begin with, I want to mention that femoral neck fracture is a serious problem which affects about 30,000 people in Poland annually. The most important risk factors of these fractures are smoking, white race, female sex, and of course, increasing age. That's why we should pay particular attention on that problem, which will definitely become more frequent in the coming years. Now I want to tell what was the aim of our study. So, we aimed to create a patient's profile and assess treatment methods for femoral neck fractures amongst patients treated at the Department of Orthopedics and Traumatology in Katowice-Ochojec at years 2021 to 2023. Now I want to explain the materials and methods which were used. So, in our study, an analysis of 157 cases of femoral neck fractures was conducted. Data from these cases was divided according to the Gardens and Powell's classification, age of patients, time from injury to surgery, methods of treatment, and type of injury, whether it was high or low energy trauma. Powell's angles were measured by a student supervised by our tutor using Radiant Diacom Viewer program. Now moving on to Gardner's classification, and as I said before, patients were divided according to this classification. This classification takes into account a type of damage and the displacement of fragments. Four types are distinguished here. In the first type, there is no displacement. The second can also be non-displaced, or the displacement is very slight, resulting from complete cortical layer damage. In the third type, there is a partial displacement, and in the fourth, there is a complete displacement. As you can see, most of our patients were classified as a third degree in Gardner's classification. Moving on to Powell's classification, I want to explain what is it. So, the Powell's classification is based on the angle of inclination of fracture to the horizontal level. As you can see, three types are distinguished here. In the first type, the angle is within the range of 0 to 30 degrees. When this fracture happens, compressive forces prevail over shearing forces, and the risk of complication is minimal. In the second degree, the angle is within the range of 30 to 50 degrees, and the risk of complication is slightly higher. Also, there is a third type of Powell's when the fracture is above 50 degrees. When this fracture happens, shearing forces prevail over compressive forces, which creates significantly the worst conditions for union and increasing the risk of complications, such as avascular necrosis of the head of the femur. As you can see, most of our patients were classified as the worst, third degree in Powell's classification. Now I want to explain treatment methods for femoral neck fractures which were used. So, nearly 11% of our patients were disqualified from surgical treatment due to existing internistic contraindications. These patients were treated using non-invasive methods. The rest of our patients were treated surgically. As you can see on the screen, the methods of treatment was internal fixation, it means neck screws or gamma nail fixation, partial hip replacement, or total hip replacement. As you might already notice, the average age of patients treated non-surgically was slightly higher than the average age of patients treated surgically. Also, there was observed that the average age of patients was different for various procedures. The youngest group was created by patients treated with methods of internal fixation. The oldest group was created by patients treated with total hip arthroplasty, and this average age of this group was even slightly higher than the average age of patients treated with non-invasive methods. Moving on to the results, I want to explain that there was a correlation between the gender and age and the degree in the Powell's scale, as well as between age and the degree in Gardner's scale. It indicates that in all the patients, fractures with poorer prognosis are more prevalent. Also, additional burdens resulting from age, sometimes poorer economical status, exacerbate the difficulty in achieving therapeutic goals in this group age. To conclude, I would like to underline the role of the careful examinations of patients' contraindications before surgical treatments, since the risk of avascular necrosis is definitely higher for patients with atherosclerosis and diabetes. Also, age is a negative prognostic factor in treatment for femoral neck fractures, not only because of the age of patients and their contraindications, but also these patients get worse fractures both in Gardner's and Powell's scale. And thank you for your attention.
Now I would like to invite you all to ask questions and discuss the presented paper. Any questions?
Ryszard Tomaszewski. Congratulations for a very interesting presentation and a really very big group of patients. 2 years and 150 patients is a very big patients group. But my question is, of course, we can choose the treatment, the mode of treatment. We can choose the gamma nail or prosthesis. But my question is, choosing depends of the experience of the patient, of the surgeon. And what about the follow-up of these patients? Are you looking for this?
We were checking the follow-up, and to be honest with you, we discovered that the average survival of patients treated with methods of internal fixation was slightly higher than for the patients treated with other surgical methods.
Thank you a lot. We have other question to our presenter. Okay, so thank you.
Thank you very much.
So I can invite you to a second presentation, Gabriela Kwoka. Assessment of pediatric patients with arthrogryposis using the PODCI scale.
So good afternoon, ladies and gentlemen. On behalf of Student Physiotherapy Research Club in Pediatrics, I would like to present you the results of our work on assessment of pediatrics patients with arthrogryposis using the PODCI scale. Arthrogryposis refers to a group of rare conditions characterized by congenital joint contractures in 2 or more areas of the body. In children with arthrogryposis, there is observed limitation in independent functioning and self-care compared to the healthy pediatric population. However, despite significant difficulties associated with the movement restrictions, individual compensatory mechanisms allows to performance of basic activities and in the environment. The aim of the study was to perform a functional assessment of pediatric patients with arthrogryposis using the Polish-validated pediatric outcome data collection instrument. The use of this tool allowed describing patients in terms of gross motor function, fine motor skills, self-care, and quality of life. Study included 52 pediatric patients treated for arthrogryposis at the University Children's Hospital in Krakow. PODCI was intended to be completed by parents, and depending on the child's age, a scale designed for the age range of 2 to 10 and 11 to 18 years old was utilized. Importantly, in the PODCI scale, the results are converted in such way that we must remember that the lower the total result child obtains, the worse his functional level is, or it is in more pain, for example. Okay, so among all domains, pain comfort scale has the greatest impact on the overall assessment of functioning. And looking at the graph of relationship between a child's functioning and pain, we can notice that the results are consistent with expectations, meaning the less pain child experiences, the better they function. And this one argument indicating that the PODCI is a very good scale for assessing children with arthrogryposis, and it confirms the actual importance of its validation. Now, looking at the graphs, it can be said that sport and transfer domains do not significantly affect the sense of happiness. and quality of life. The correlation is positive, however, coefficient is not strong, but rather moderate, which may be due to a wide range of functional levels among children and individual cases. We also explain it by the primary compensation that children develop practically from the first days and weeks of life, when they learn how to function with their bodies and control them. Because a child born with contracture learns how to function with them, and at this level, it is satisfactory for them, both in terms of basic mobility and recreational activities with other children. And a domain that correlates most strongly with quality of life is upper extremity, which proves that this aspect is crucial for treating children with arthrogryposis. And if there are problems in this area, it significantly lowers the level of life satisfaction. Therefore, the priority in rehabilitation should be hand therapy, especially in terms of self-care and activities of daily living. Coming to conclusions, of all domains, pain has the greatest impact on global functioning. The sport and transfer domains don't significantly affect the sense of happiness. And domain that correlates most strongly with happiness is upper extremity. Therefore, hand therapy should be given high priority. However, it can't be overlooked that on all charts, we also observe spread of results concerning individuals, indicating that each patient should be looked at individually. Thank you.
I invite to discussion. We have any question to this presentation? Perhaps one.
I would like to know what kind of activity did you offer to your patient for the hand improvement, I would say.
Okay. So I would say I would focus on improving all the things which are important in daily living, because some contractures are really serious and the children can't, for example, even hold the something to write or to eat, and it's very hard for them to function in everyday life. So I don't think it should be very specific or rehabilitation on very high level. I think that we should start with just basic activities of daily living for these children to be satisfied with life and with everything.
Starting from the beginning.
Yeah.
Thank you.
Thank you a lot.
Thank you.
We can run to the next presentation. The next presentation is the influence of hamstring muscle stiffness on the control of pelvic position in a group of children from the Silesian agglomeration by Krzysztof Świątek.
Dzień dobry, szanowna komisjo, szanowni państwo, drodzy słuchacze oraz koledzy i koleżanki. Nazywam się Krzysztof Świątek i jestem studentem Śląskiego Uniwersytetu Medycznego na kierunku fizjoterapii. I dzisiaj będę mieć przyjemność i zaszczyt przedstawić wyniki naszych badań w związku z tematem, jakim jest wpływ sztywności mięśni kulszowo-goleniowych na kontrolę ustawienia miednicy w grupie dzieci z aglomeracji śląskiej. Temat ten opracowaliśmy również z pomocą i asystą naszych prowadzących z koła rehabilitacji. Przede wszystkim chciałem trochę zacząć od tła, czemu jakby trochę zabraliśmy się za ten temat. Przede wszystkim w związku z spadkiem aktywności fizycznej u dzieci. To można było przede wszystkim zaobserwować, jeżeli Państwo śledzi badania programu Matrix 4.0 wykonane na ramach roku 2022, gdzie tylko 20% dzieci w Polsce spełniało te normy właśnie prawidłowej aktywności fizycznej. I przede wszystkim idąc dalej, w momencie, kiedy nie ma tej aktywności fizycznej, trudno jest o odpowiednią elastyczność mięśni, żeby spełniały tę funkcję. I przede wszystkim jeszcze dodatkowymi czynnikami, które wpływają na aktywność tych mięśni, to jest płeć, na której się akurat skupiliśmy, wspomniany tryb życia oraz czynniki anatomiczne. Na początek przedstawię kilka pojęć, żebyśmy wszyscy mieli pewność, w jakim temacie się poruszamy. No to przede wszystkim skupiliśmy się na grupie mięśni kulszowo-goleniowych i potraktowaliśmy głównie je jako całość, ale przybliżając, ta grupa składa się właśnie z trzech mięśni. Jest to półboniasty, półuścięgnisty, dwugłowy uda, które przyczepiają się do guza kulszowego, poza oczywiście głową krótką, dwugłowego, który przyczepia się do kresy chropowej. No i przyczep końcowy właśnie dwugłowego to jest głowa strzałki. I przede wszystkim te mięśnie zajmują się, ich funkcja to zginanie w kolanie, w stawie kolanowym, prostowanie w stawie biodrowym, przywodzenie biodra oraz też są rotatorami. Jak już wspomniałem o miednicy, to też przytoczę bardzo ważny temat, czyli kontrola miednicy. Tutaj przede wszystkim skupiliśmy się na przodo- i tyłopochyleniu, czyli właśnie ruchach w płaszczyźnie czołowej, czyli no, przodopochylenie to jest właśnie obniżenie przedniej części z podwyższeniem górnej i analogicznie właśnie jak jest, no, mówimy o tyłopochyleniu, to obniżenie tyłu, podniesienie przodu. I jeden z tematów, który też będzie bardzo istotnym testem, który porównywaliśmy a propos sztywności mięśni kulszowo-goleniowych, czyli właśnie kąt dopełnienia, jest to kąt między osią podłudzia a osią pionową kończyny dolnej. I jest to badanie, które, jak już wspomniałem, to jest badanie na wymierność sztywności grupy kulszowo-goleniowej. I przede wszystkim jest przeprowadzane w pozycji, kiedy pacjent leży tyłem, biodro jest zgięte w 90 stopniach i wtedy przy stabilizacji drugiej kończyny prostujemy ją do oczywiście odczuć pacjenta albo nieprzyjemnych bólowych bądź do sztywności twardej. I naszym celem było określenie wpływu sztywności grupy kulszowo-goleniowej na kontrolę ustawienia miednicy w grupie dzieci aglomeracji śląskiej i ze względu na płeć. Nasze badanie retrospektywne było prowadzone w ramach pilotażu stóp. Jest to program NFZ. Zostało przeprowadzone na grupie 294 dzieci, w tym to było 137 dziewczynek i 157 chłopców. Średni wiek w grupie dziewcząt to było od 9,9 plus minus 2,69, a u chłopaków to było 9,61 plus minus 3 i wszyscy badani pochodzili z aglomeracji śląskiej. I Przede wszystkim to też zapewne Państwo mogli się też zdziwić, jak to studenci przeprowadzali takie badania. Otóż my asystowaliśmy przy tych badaniach, bo te badania były przeprowadzane przez wykwalifikowanych fizjoterapeutów, przede wszystkim naszych opiekunów koła, czyli pana doktora Wnuka oraz magistra Kroczka. Są to wykwalifikowani fizjoterapeuci z wieloletnim już doświadczeniem i przede wszystkim też to była dla nas bardzo dobra nauka, gdyż zobaczyliśmy pewną ciężkość pracy z dziećmi. Dzieci przede wszystkim się stresują, a czasem nawet bardziej niż dzieci to ich rodzice, że to też nauczyło nas tej relacji terapeuta-dziecko, a terapeuta-rodzic. Z tym różnie bywało. Przede wszystkim badaliśmy te dzieci pod względem 3 testów. To był właśnie testowaliśmy właśnie te ruchy przodo-tyło pochylenia, test właśnie kąta dopełnienia oraz test palce-podłogę. Tutaj właśnie mamy przykładowe grafiki. Właśnie test Tomajera przede wszystkim polega właśnie, że dziecko się musi pochylić do przodu i utrzymać proste kończyny. Drugim testem tutaj też chciałem zaznaczyć, że to może nie być widoczne, bo to miało być, że bardziej właśnie jak wspomniane przeze mnie, że miednica, zgięcie w biodrze musi być 90 stopni i oczywiście ze stabilizacją drugiej kończyny przez drugiego terapeuta. I też chciałem powiedzieć, że ważnym w trakcie tego badania, bo to był kompleks badań, który trwał łącznie 45 minut, ale o tych innych badaniach już powiedzą moi koledzy bądź koleżanki. Staraliśmy się zapewnić jak największy komfort dla dzieci, jak i rodziców, żeby przede wszystkim żeby uniknąć tego napięcia poprzez stres oraz również komfort termiczny. No i przede wszystkim w badaniach i metodach wykorzystaliśmy program Statistika Soft i dla przyjętego poziomu istotności to jest 500 i normatywność tego rozkładu zmiennych badaliśmy za pomocą testu Shapiro-Wilka w celu weryfikacji hipotezy właśnie dotyczącej różnicy między kobietami a dziećmi i parametryczny test studenta dla zmiennych niezależnych oraz właśnie test Umana-Whitneya.
Skończył nam się czas. Prosiłabym o przejście do wniosków.
Dobrze. Przejdę do wniosków. Akurat w związku z tymi badaniami wyszły nam statycznie istotne dane, iż w grupie dziewcząt faktycznie zachodzi, ta sztywność jest mniejsza w porównaniu do mężczyzn, dlatego też możemy śmiało wysnuć wnioski, iż występuje korelacja między płcią a sztywnością mięśni kulszowo-goleniowych, a więc i wpływem na ustawienie miednicy.
Thank you a lot. I would like to invite to go to discussion. Any question for other presenter?
Gratuluję pracy, bo jest generalnie trudna. Nie zdążyliśmy zapoznać się z metodologią, więc nie mam się do czego odnieść, ale wspomniał Pan o tym, że są to badania retrospektywne. Czy w takim razie mieliście Państwo już gotowe dane i gotowe wyniki, czy tylko analizowaliście je?
Znaczy, każdego pacjenta właśnie analizowaliśmy jakby w trakcie, bo to też te badanie, jakby cały pilotaż stóp dalej trwa i my akurat skoncentrowaliśmy się na tej grupie, co wiedzieliśmy, że jesteśmy w stanie przebadać pod tym kątem i te wyniki przede wszystkim my właśnie je pozyskiwaliśmy, analizowaliśmy i właśnie wykorzystywaliśmy je do analizy statystycznej.
Czyli to nie są retrospektywne, czyli to nie są dane, które już zastaliście Państwo. A w jaki sposób ocenialiście sztywność?
Sztywność ocenialiśmy za pomocą właśnie testu Thomajera i właśnie też za pomocą kątu dopełnienia właśnie w ten sposób, jak testu kąta dopełnienia i w ten sposób właśnie jak to za pomocą właśnie inklinu metra.
Dziękuję.
Dziękuję również.
Ja mam jeszcze takie pytanie, bo akurat też miałem taką przyjemność, żeby badać sztywność pasywną grupy kulszowo-goleniowej na takim dość dużym badaniu, co prawda tyczącym się osób dorosłych, ale chciałem zapytać, czy oceniliście Państwo poziom istotności statystycznej tych testów, właśnie poziomu dopełnienia kąta, bo przyjęliście strategię, jak dobrze Pana usłyszałem, pod kątem odmowy do bólu lub do końca jakby zakresu mobilności. My przyjęliśmy strategię opisywaną w literaturze, że mieliśmy konkretną wartość na wadze uzyskać. Więc chciałem właśnie o to zapytać, bo my mieliśmy z tym problem, żeby to zrobić właśnie do odmowy przez właśnie brak rzetelności tych testów. Czy ocenialiście Państwo rzetelność tych testów pod kątem właśnie testu dopełnienia kąta i testu palce podłoga?
A to akurat musiałbym się dopytać opiekuna, to czy panie doktorze, mógłby pan podejść i odpowiedzieć na to pytanie, gdyż
chodzi o test palce podłoga, to znaczy takiej stricto rzetelności, znaczy wykonywaliśmy test do pierwszego rozciągnięcia. Zarówno testu dopełnienia, a jeśli w przypadku testu tutaj pochyleniowego, testu Thomajera, to też braliśmy pod uwagę tą różnicę, jaką brakuje osobie do dotknięcia palcu podłogi, tak? Czyli to zapisywali. To było trzykrotne, ale za każdym razem tutaj braliśmy to pod uwagę taką średnią, albo tutaj też średnią tych trzech prób.
Thank you a lot. It's finish our discussion. I can invite you to next presenter. The next presentation is abstract assessment of sagittal spinal curvature under isometric tension depending on gender in children by presenter by Michał Nowak.
Hello, ladies and gentlemen. John? Hello, ladies and gentlemen. My name is Michał Nowak, and I will be presenting our project. So, children and teenagers are prone to postural alternations due to their still developing muscular and skeletal systems. Thankfully, because they are still developing, the rehabilitation of postural changes arising from bad habits is quite efficient. A defective posture działa czy nie działa? No właśnie. Dzięki.
Inaczej trzymać.
Okay. So, defective posture might be a manifestation of muscular disbalance and low muscle strength. Therefore, determining the endurance of said muscles is an important part of posture evaluation. That brings us to our study, the aim of which was to investigate the effects of isometric tension on sagittal spinal curvature in children, with a focus on gender differences. In addition to all of that, we measured the Clark's angle of the participants' feet. The Clark's angle is the main diagnostic method for flat foot, and the occurrence of flat foot is positively correlated with bad body posture. So, this study was also a retrospective study. Data was collected during months of pilot program for feet examination in children held in the Katowice hospital. The subjects were children from the Silesian agglomeration, 71 in total. We used the DRS system and VRS video stereography. The kyphosis and lordosis of the participants was assessed in both the relaxed position and in the Matthias test. Clark's angle was measured using a goniometer. When it comes to the statistical analysis, we used the Shapiro-Wilk test for normality, the student test, and Mann-Whitney-U test for gender differences. Here we can see the photos of the process of measuring the spinal curvatures in this study. On the left, we can see a patient standing in the relaxed position. And on the right, the girl is performing the Matthias test. The Matthias test is a clinical test that determines the endurance of postural muscles of the trunk. So, our results regarding kyphosis and lordosis angles, there were no significant gender differences in both relaxed position and the Matthias test. The findings for Clark's angle were similar, no significant differences between boys and girls. Let's go to the tables, and as you can see here, the values of the spinal curvatures are really similar. So, for example, the mean angle of lordosis in boys in freestanding position is 40.8 degrees, and in girls it's 43.4, which is not a big difference. As stated before, there are no statistically significant differences in values of Clark's angle between genders. And for the discussion, I prepared a couple of scientific papers that may corroborate or challenge our findings. So, as we can see, there is a lack of large postural differences. This is something that was also observed in a number of different sources with larger numbers of subjects. So, for example, there are two studies by Łapkowska and others that show that about 32% of girls and about 32% of boys participating in those studies have improper posture. Both studies encompassed 500 children each, so way more than our study. Another study found that the spinal postural disorders were similar between young school boys and girls. But what Georgi and others found was that there was a big difference between preschool boys and girls. So, namely, it was 11.4% boys and 34.5% of girls had a kyphotic posture. And that brings us to one of the possible critiques of our study. The children weren't in their respective age categories because, well, the differences could be significant in different ages, and we recognize this limitation. I have to skip a little because we are out of time. So the conclusions of our study are that the postural muscle strength is similar in both genders. The results may have an effect on clinical practice. Understanding that gender does not significantly influence sagittal spinal curvatures in both genders can influence approaches in pediatrics. And our recommendation for further research is a large-scale study with a bigger control group, a bigger group of patients. And that's about it.
Thank you for your presentation. I would like to invite you to all to ask questions and discussion. We have any question?
Congratulations on the study. I've got questions. What was the inclusion criteria to the study? Were kids, did they have any problems with the body posture? And why did you expect that there would be any differences in this age group? In terms of lordosis and kyphosis.
Okay, so to answer the first question, there were not many criteria. It was just the age between 5 and 16. And to answer the second question, in the studies that I read, there were a lot of wait, let me try again. The studies categorized children based on their age, and in a lot of them, there was quite a significant difference in the body posture. So, for example, the kyphotic posture or kypholordotic, and it changed depending on the age of the children.
Okay, but you compared boys to girls. I didn't mention what was the mean age, because there's a big difference between 5 and 16. So what was the mean age in the first group and the second one?
I don't know that. I'm sorry.
Thank you.
We have any other questions for our presenter? Okay, so we can finish the discussion. Now I would like to invite the work by presenter by Cabaj Anna, assessment of flat foot prevalence by gender in a cohort of children from the Silesian agglomeration.
Dzień dobry, szanowni państwo, droga komisjo. Nazywam się Anna Cabaj. Jestem studentką 3. roku fizjoterapii na Śląskim Uniwersytecie Medycznym w Katowicach. Wraz z koleżankami z Koła Naukowego Katedry i Kliniki Rehabilitacji przygotowaliśmy dla państwa prezentację pod tytułem Assessment of Flat Foot Prevalence by Gender in a Cohort of Children from the Silesian Agglomeration. Stopa, będąca głównym punktem kontaktu z podłożem, musi zapewniać organizmowi dobrą amortyzację podczas ruchu, zdolność dopasowania do podłoża podczas ruchu oraz mocne odbicie dla sprawnego i ekonomicznego ruchu. Podstawową cechą pozwalającą na realizację wymienionych zadań jest charakterystyczna, wewnętrzna oraz zewnętrzna architektura stopy oraz wzmacniający ją system stabilizatorów czynnych, czyli mięśni, oraz stabilizatorów biernych, torebki stopowej i więzadeł. Przy zachowaniu prawidłowej budowy i czynności wszystkich elementów tworzących oraz zaopatrujących stopę zaobserwować można fizjologiczne, charakterystyczne ukształtowanie sklepień stopy oraz brak zaburzeń podczas lokomocji. W przypadku występowania patologii którejś ze struktur może dojść do wadliwego ustawienia stopy, niekiedy rzutującego na jakość lokomocji. Płaskostopie jest często spotykanym problemem wśród dzieci. Niejednokrotnie może stać się przyczyną rozwoju innych wad postawy w związku ze zmienioną biomechaniką ciała. Zrozumienie różnic między płciami może pomóc w lepszym doborze możliwych strategii terapeutycznych oraz działań profilaktycznych. Badania realizowane były w ramach pilotażowego programu badania stóp dzieci na Śląsku, finansowanego ze środków Narodowego Funduszu Zdrowia. Celem przeprowadzonych badań była ocena różnic częstości występowania płaskostopia podłużnego między płciami wśród dzieci aglomeracji śląskiej. Grupa badana składała się ze 196 osób z podziałem na 104 mężczyzn oraz 92 kobiety. Średni wiek kobiet wyniósł 9,8 lat, średni wiek grupy chłopców był zbliżony i wyniósł 9,7 lat. Dodatkowo w trakcie badań uwzględniono procentowy udział występowania koślawości kolan, koślawości tyłostopia oraz płaskostopia poprzecznego w badanej grupie z podziałem na płeć. Procentowy rozkład badanych zmiennych wykazał różnicę między płciami, jednak po przeprowadzonej analizie statystycznej wykazano, iż ten wynik nie jest istotny i nie wykazuje korelacji z częstością występowania płaskostopia podłużnego w badanej grupie. Pomiar został wykonany za pomocą systemu FootScan oraz podoskopu. W trakcie badań obraz z podoskopu rejestrowany był za pomocą fotografii cyfrowej w celu wykonania pomiarów przy użyciu oprogramowania programu Corel Unit Photo Impact X3. Najbardziej widoczna część stopy odpowiadała strefie nacisku na podłoże. Wykorzystując funkcję programu, wykonane zostały pomiary wartości wysklepienia stopy metodą Clarka oraz wskaźnik Weisfloga. Analizę statystyczną przeprowadzono przy użyciu oprogramowania Statistika StatSoft, gdzie istotny poziom istotności uwzględniono jako 0,05. Normalność rozkładu zmiennej badano za pomocą testu Szaripo-Wilka, a weryfikację hipotezy dotyczącej różnic między płciami przeprowadzono przy użyciu parametrycznego testu Dlenta dla zmiennych niezależnych oraz nieparametrycznego testu Humana-Whitneya. Analiza statystyczna nie wykazała istotnych różnic między płciami częstości występowania płaskostopia podłużnego w badanej grupie dzieci. Kobiety i mężczyźni charakteryzują się podobną wartością kąta Clarka dla stopy prawej oraz dla stopy lewej. Obliczona wartość środkowa informuje nas o tym, że wśród kobiet i mężczyzn występuje stopa normalna. Dodatkowo uwzględniając inne parametry, takie jak koślawość kolan, koślawość tyłostopia oraz występowanie płaskostopia poprzecznego, nie wykazano korelacji z częstością występowania płaskostopia podłużnego z podziałem na płeć. Na podstawie przeprowadzonych badań wyciągnięto wnioski, iż występowanie płaskostopia podłużnego nie jest skorelowane z płcią. Dziękuję za uwagę.
Thank you for your presentation. We can start the discussion. Dear jury, you have any question for this project?
Ja tylko jedno małe pytanie. A w jakim wieku, w jakim przedziale wiekowym były dzieci, które Państwo badaliście? Bo chyba umknęło mi coś na prezentacji. Znaczy poniżej 18, czyli od którego do którego? Czyli i w przedszkolu badaliście Państwo, tak? Aha, do szpitala na Ochojca. Aha, rozumiem, dziękuję. Czyli nie dzieliliście Państwo na grupy wiekowe? Nie.
Any other question for our presentation? Okay, thank you. We can finish the discussion. I would like to invite the next presentation, number 6. It will be reaction time. Is it a skill that can be trained? Presenter by Ewa Filczak.
Good morning, ladies and gentlemen, dear commission. Today, my name is Ewa Filczak and I'm a fourth year student of physiotherapy. And with my colleague Julia, I would like to present our work. Reaction time, is it a skill that can be trained? Table tennis is a sport influenced by numerous factors that determine mastery and achieving high level of performance. These factors encompass technical preparation, tactical acumen, physical preparation, motor skill, physical fitness, players' talent, development opportunities, and others. Currently, the game has intensified in pace. Observing the world's best player, one can discern a heightened dynamism compared to the past. Agility and speed at the table are pivotal. The contact of the racket with the ball lasts only about 0.001 second. The action unfolds swiftly within a confined space, necessitating rapid reaction and the ability to anticipate the game's trajectory. The aim of the study to determine whether table tennis training improve reaction time and whether variables such as age, gender, playing experience, length, and the frequency of the session influence players' reaction speed. Methodology. In the study, involved testing 100 participants comprising 34 women and 66 men aged between 6 and 75 years. Participants were divided into two groups. A study group consisting of amateur table tennis practitioners spanning various age group, and a control group non-training this sport. Among table tennis players, data were collected regarding years of trainings, frequency of session per week, and session duration. The research methodology included two rapid tests. The Dietrich stick grip, who assessing simple reaction, and the crossline apparatus measuring choose reaction time. The results: study group versus control group. Upon comparing the results of the both group, it was observed that in the Dietrich stick grip test, the control group exhibited superior results in the both hands, with this difference being statistically significant. And the next, this is a diagram for right hand, and the next one is the left hand. Thank you. The next one, dependencies with aged, and a slight improvement in the reaction time. Crossline was noted with adults demonstrating greater concentration abilities during the trial compared to younger participants. Women versus men in both groups. The research revealed no gender-based difference among all respondents. And the next one, women practicing table tennis versus women non-training. The study also included that women who didn't engage in table tennis training exhibited faster reaction times with the right hand compared to women practicing table tennis. And the next one is men practicing table tennis versus men non-training. That similarly among men, the non-training group demonstrated faster reaction times than players in both hands this time. Study group. in observing table tennis players, relationship between players' age, playing experience, training duration, and their reaction time were noted on the cross-brace apparatus. The average reaction time in both the dominant and non-dominant hand decreased with increasing playing experience. While the dominant hand is primarily used in table tennis, the non-dominant hand also play a crucial role, particularly in ball toss during serves or maintaining balance during the dynamic action, for example, making top spins. And the conclusion. Next one. Thank you. Conclusion. In conclusion, the study indicated that amateur table tennis players don't necessarily require above average reaction time at this level. Training, individual predisposition, and player characteristics play a more significant role. Physical fitness and anticipation appear paramount at this level. Additionally, it can be inferred that the control group's performance was not adversely affected by training intensity. Notably, the players were in preparation for significant events such as Polish championships or Silesian championships that across around age categories, which could have led to training related stress. This topic warrants future exploration. Thank you so much. And
thank you for your presentation. I would like to invite you to ask a question for this presentation. We have any from jury?
I guess you divide people into the study group and control group according to someone is playing or not. But the range of age was 6 till 75. So what was the training experience in the study group?
The study group, children with 6 or 7, 8 years, they start training table tennis. So they have a month or 2 months play. And 75 years old, that's a person who played 10 years and have a small pause with adults, and they practice 2 times per week. So they train a lot small.
Thank you, but they were all in the same group.
Yeah, there's a group for children group have start adventure with table tennis, and we have a lot of people than adults or person who work. They train, and we have a older person, and we have 4 or 5 groups, training groups.
Thank you. It's interesting study, but I guess it would be better to divide the study group into some age groups.
Thank you so much.
Thank you. We have any other question? Okay, so thank you. We can stop the discussion. The next presentation will be Quality of Life After Total Knee Replacement Surgery, presented by Jakub Rudzki.
So good afternoon, everyone. My name is Jakub Będkowski, and I'm here to present you our research about quality of life after total knee arthroplasty. So what is osteoarthritis? Osteoarthritis is the most common type of arthritis, which is primarily responsible for the degeneration of the cartilage within the joint, and it affects over 500 million people worldwide. When it comes to knee itself, it's the most frequently affected joint, with 365 million patients. As for the cause of this disease, it is not fully discovered, but it is believed that the combination of genetic, mechanical, and environmental factors plays a crucial role in its development. So how can we fix it? So these are various methods to slow down the progression of this disease. But due to the irreversible nature of the damages done by osteoarthritis, the most reliable and the most efficient way to do it is to perform total knee arthroplasty. This procedure includes removing the damaged and diseased cartilage and bone with leaving the healthy bone intact, and then implanting the artificial parts to the kneecap, thigh bone, and shin bone. The main cause of performance of the surgery is, of course, to improve overall quality of life of our patients, which includes easing the pain and helping them to overcome the everyday problems caused by arthritis. It is also worth mentioning that this procedure is increasingly performed. We observed the average annual increase of 156% between years 2000 and 2019, with 790,000 operations performed only in the USA. So our aim was to compare the patient's quality of life before the surgery and after the surgery with the help of Oxford Knee Score. So Oxford Knee Score is a patient-reported outcome measure that consists of 12 questions. They are focused on level of function, problems in daily activities, and how the pain have affected our patients in a time of previous 4 weeks. Each question is scored from 0 to 4 points, where 0 means the worst and 4 means the best outcome. The maximum score you can get on this scale is 48 points, which may indicate satisfactory joint function. But on the other hand, the worst you can get is 0 points, and this may indicate severe knee arthritis. So, for our methods, we prepared the retrospective single-center study of medical documentation of patients with TKA procedure treated in the Department of Orthopedic Trauma, Oncologic and Reconstructive Surgery at the Provincial Specialist Hospital No. 5, named after St. Barbara in Sosnowiec. For the needs of our study, we enrolled 100 patients who were treated by TKA between March of 2022 and March 2023. When it comes to demographic data, our study group consisted mainly of women. The mean age was 68.97 years and BMI 30.52. 75% of our patients suffered from comorbidities, from which the main one was hypertension, followed by thyroid diseases and diabetes. Almost every of our patients has undergone physical therapy after the surgery. And as you can see on the right side, the 95% of our patients were operated because of the primary cause, and 58% of the operations were performed on the left knee. When it comes to the results, we can see that before the operation, the mean score of OKS was 18.41, but following the operation, we can see an improvement to the average of 37.56. And that's the mean difference of 19.15 points. But these are only the overall results. We divided the 12-question questionnaire into 3 groups named pain, movement, and daily activities to take a closer look at each question. So when it comes to pain, the biggest difference was observed in the question number 1 regarding the overall pain perception in the knee, with a mean difference of 2.69 points. When it comes to movement, we can see that the biggest improvement was observed in question number 6, regarding limping with a mean difference of 2 points. But we also should take a look at the question number 7, which has shown a difference of only 0.58, which may indicate that even after successful TKA, patients still may have problems with kneeling down and standing up from the kneeling. When it comes to daily activities, the biggest improvement was observed in question number 3 regarding getting in and getting out of the car, with the mean improvement of 1.67 points. And moving on to the conclusions, we observed that all of our patients experienced a significant improvements in their quality of life in various dimensions. The most notable improvement was in pain perception, including nighttime pain. But we also need to acknowledge our study's limitations, which includes a small sample size of only 100 individuals, and this can potentially limit our ability to generalize our findings. Thank you very much for your attention. And do you have any questions?
Thank you. We have any questions from our jury?
Very interesting study. Could you tell us what was the time of the follow-up? I mean, how long after surgery did you assess the quality of life of patients?
Yeah, so we reach out to the patients that are 6 months or later after surgery to give them time to get a rehabilitation properly, to assess the quality of life But it was the time span of 6 months to 12, 13 months after the surgery.
Thank you.
Congratulations for this work, very interesting. But my question is, when to start with the arthroplasty? Have you some indication for this?
Yes, so of course there's the assessment by the Oxford knee score, as I said, but also in the hospital we use surgery qualification card to determine if a patient is qualifying or not qualifying to the surgery. This includes, of course, the age of a patient, his BMI, previous infections, and other health problems. But of course, as you saw on the slide with Oxford knee score, we can divide this arthritis to the severe, moderate, and fairly functional joint. So I would say that we just want to base on an Oxford knee score, but then provided with a qualification card in a hospital that can show us that the patient is qualified or not qualified to the surgery.
Thank you a lot. Any question? Okay, so I think that we can finish the discussion. Thank you for your presentation. The next presentation is the quality of life after total hip arthroplasty, presented by Kacper Solarz.
Hello, ladies and gentlemen. My name is Kacper Solarz, and today with my colleagues, we would like to present you with our study on patients' quality of life after total hip arthroplasty. First of all, it's important to highlight the importance of this procedure as a treatment method for osteoarthritis, given it's a worldwide disease affecting more than 528 million people. 47% of people over the age of 65 suffer from some kind of osteoarthritis. This condition results from a gradual breakdown of joint cartilage and leads to chronic pain, reduced mobility, and diminished quality of life. While the exact cause of osteoarthritis is not known, it's highly believed that it's a combination of genetic, metabolic, mechanical, and environmental factors that play a vital role in its pathogenesis. As for total hip arthroplasty, it's a surgical procedure that has revolutionized the treatment of hip joint diseases, alleviating pain and improving mobility for millions of individuals worldwide. THA focuses on removing the damaged bone with cartilage and replacing it with prosthetic components. It's also worth highlighting that between the years 2000 and 2019, the estimated annual volume of THA increased by 177%, reflecting the growing importance of this procedure in healthcare. As for Oxford Hip Score, it's a patient-reported outcome measure specifically designed to assess function and the quality of life of patients who have undergone THA or are considering it. It's a 12-question questionnaire with various questions covering different aspects related to the hip. Scores from 0 to 9 indicate a severe hip arthritis, and scores from 40 to 48 may indicate a satisfactory joint function. As mentioned, there are 12 questions. Each question has a response scale of 0 to 4, allowing for a precise evaluation. A response of 0 indicates a severe dysfunction, while a response of 4 indicates a satisfactory state. In our study, we decided to split the 12 questions into 3 groups, them being pain, walking, and daily activities. Our aim was to compare the patient's quality of life before and after total hip arthroplasty using the Oxford Hip Score. As for our methods, our study was a retrospective single-center study of medical documentation of our patients treated in the orthopedic trauma, oncologic, and reconstructive surgery in Provincial Specialist Hospital number 5, named after Saint Barbara in Sosnowiec. In our study, we enrolled 100 patients who were treated with THA method during the period of March 2022 and March 2023. As for our demographic data, we had 51 male patients with a mean age of 65.3 years. Mean BMI was 29.6. 71 of our patients had comorbidities, of which 54 were hypertension, 15 thyroid diseases, 11 had diabetes, 5 had arrhythmias, and 21 patients had other comorbidities. 86 of our patients underwent physiotherapy after the surgery. Regarding the operated hip, 52 of our patients had the right hip operated and 48 had the left hip operated. As for the indication for surgery, 91 of our patients had the hip operated due to primal degenerative disease, joint disease. 3 patients had the hip operated due to injury, and 6 patients had other indications for surgery. As for the results, in the pain group, we reported the biggest improvement in how the overall pain perception, closely followed by the pain perception during the nighttime, with a mean difference of 299 and 2.9 adequately. The lowest improvement was noted in the sudden appearance of severe pain, with a mean difference of 0.83. As for the walking group, the biggest difference was noted with limping, with a mean improvement of 2.57, while the lowest improvement was noted with the patient's ability to climb a flight of stairs, with a mean difference of 1.79. As for the daily activities, the biggest difference was noted in how the hip affected the daily household chores, with a mean difference of 2.63, while the lowest improvement was reported in the patient's ability to wash and dry themselves, with a mean difference of 1.33. As for our conclusions, the results of total hip arthroplasty are favorable. The most significant improvement was noted in pain perception and pain perception during the nighttime. The least substantial improvement was noted in sudden pain appearance. And it's also worth noting that a thorough patient evaluation, particularly through tools like the surgery qualification card, plays a crucial role in determining the success of total hip arthroplasty. Thank you for your attention.
Thank you for your presentation. We have any question from our jury?
I would like to know why in your group was only men?
Maybe I presented it in the wrong way. There were 51 men and 49 women, but there was a total of 100 patients.
Your presentation table wasn't included the woman, so you have to make focus on it a little bit more.
Maybe we should have split it in. I mean, there was 51% male patients in the presentation. We didn't show the female patients.
Okay, thank you very much.
Thank you. Any other question for our presenter? Okay, so thank you. We can finish the discussion. Thank you for your presentation. The next one presentation will be back pain and physical activity level in physiotherapy students, presented by Ewelina Roszkowska.
Honorable jury, ladies and gentlemen, welcome. My name is Ewelina Roszkowska. I am a physiotherapy student of Medical University of Silesia. Today, I want to present to you my presentation about back pain and physical activity level in physiotherapy students. My work was created as a part of Student Scientific Association of Department of Kinesiotherapy and Special Methods, Faculty of Health Science. When I was doing this study, I thought about what physiotherapy students struggle with every day, and my first thought was back pain. So what is pain? Pain is an unpleasant sensory and emotional experience associated with or resembled that associated with actual or potential tissue damage. The etiology of a pain can be traumatic, degenerative, oncologic, infectious, inflammatory, metabolic, referred pain, postural, congenital, or psychiatric. Now let's move on to the study. The aim of the study was to assess the activity level of students of the Medical University of Silesia, a subjective assessment of the occurrence of back pain, and knowledge of the principles of ergonomics. Material and methods. The study included 54 physiotherapy students of the Medical University of Silesia. Students completed a questionnaire via Google Forms. The following instruments: auto survey, global physical activity questionnaire, and visual analog scale. Shapiro-Wilk test, Persman correlation, and Kruskal-Wallis test was made. A significance p-value equals less than 0.05. Now, let's see the results. 42 women and 12 men took part in this study. Average age both for women and men was 21.19 years old. I divided my results into 3 parts. The first part is all about physical activity. 11.1% of respondents do not meet the recommendation for physical activity of WHO. The respondents practice sports mostly 3 to 4 times a week. People who never practice sports did not participate in this study. Most respondents choose gym, walking, and running as their physical activity. Almost 63% of respondents practice high-intensity sport at least once a week. 66.67% of respondents practice moderate intensity sports at least once a week, and almost 65% of respondents walk or travel by bike at least 10 minutes continuously. On this chart, you can see the number of days in a typical week in which high-intensity sport was practiced. This chart shows the numbers of the days in a typical week in which moderate intensity sport was practiced. The second part of the results was back pain. 54 students, which is all of the respondents, experienced back pain at least once in their lifetime. 50% of people indicated moderate pain, 22% experienced mild pain, while 5% experienced severe back pain. 11.1% of people experience back pain every day, and 18.5% experience it a few times a week. Now you can see the degree of the pain. To sum everything up, standing and sitting turn out to be the most likely position to occur pain. Respondents experience back pain while bending, lifting weights, and walking for a long time. The average severity of pain was 4.1 in the scale of 0 to 10, both for women and men. Now you can see the Kruskal-Wallis test. No difference was observed among the frequency of pain and the sum of recreation. P-value equals 0.77. Spersman correlation. There was no correlation between severity of pain and sum of recreation. P-value was 0.19. There was no correlation between the time spent sitting and the severity of pain. The last part was about principles of ergonomics. Only 11.1% believe that they always follow the principles of ergonomics when working with patients. Most people stated that they can't apply the principles of ergonomics at university. Only 7.4% claimed that they always remember the principles of ergonomics while performing everyday activities. Conclusions. Among the 54 surveyed students, each of them experienced back pain at least once in their lifetime. The physical activity level is satisfactory among the physiotherapy students, and time spent in a sitting position or in physical activity does not affect the severity of pain. The research must be continued on a larger group in order to analyze the factors influencing the frequency and severity of pain. Thank you for your attention, and if you have any questions, please let me know.
Thank you for your presentation, so we can start the discussion.
What would you recommend to decrease the level of back pain, or as far as possible to prevent the back pain among physiotherapy students?
I think that it's really important to talk about this on classes, especially when we are working with patients. I think it will be really important to teachers to say if we are doing something wrong.
Thank you. We have other questions for our presenter. Okay, so thank you. We can finish the discussion. The next presentation will be the intensity of fatigue in Parkinson's disease patients and selected factors influencing its level, presenting by Martin Hellish.
Good afternoon, ladies and gentlemen, the Commission. My name is Martin Hellish, and together with my colleague Julia Gavron, we made the research about the intensity of the Parkinson's disease patient and selected factors influencing its level. So, the Parkinson's disease is a chronic, progressive, and incurable neurodegenerative disorder of the nervous system. Its pathophysiology is mostly notably characterized by degeneration of dopamic neurons in the substantia nigra of the midbrain. Parkinson's disease is the second most common neurodegenerative disease and the most frequent cause of the Parkinsonism. It affects approximately 10 million people worldwide. The diagnosis of the Parkinson's disease primarily relies on the clinical symptoms. The essential conditions for diagnosis is the presence of Parkinson features, bradykinesis combined with either resting tremor and/or muscle rigidity. Bradykinesis, or slowness of the movement, is the most critical symptoms and is present and necessary for diagnosis. Patients perform tasks more slowly, have difficulty initiating movements, such as taking the first step, and show a reduction in the frequency of automatic movements, such as arm swinging while walking or blinking. We also have muscle rigidity. Muscle rigidity refers to increased muscle tone of plastic type. During the examination of the muscle tone, a constant resistance is felt during the passive movement, and we call it lead pipe rigidity or cone wheel type resistance. In Parkinson's disease, tremor initially manifests as the resting tremor, meaning it occurs when the muscles are not voluntarily contracted and decreased with voluntary movements. We also have non-motor symptoms, such as neuropsychiatric symptoms, include depression, cognitive impairment, anxiety, apathy, and also we have anatomic dysfunctions, include constipation, urinary disturbance. The patients also have trouble with sleeping, and other symptoms may include olfactory dysfunction, pain syndromes, and diplopia. So our aim for this research was to know the correlation between fatigue and other variables like age, gender, or severity of disease. We also wanted to know how many people with Parkinson's disease experience high level of fatigue. For our materials and methods, the study involved 44 individuals, 18 women and 26 men, aged from 35 to 83 years. The selection for the study was purposefully, including individuals diagnosed with Parkinson's disease. The research tool was a questionnaire. Data collected included gender, age, disease duration since diagnosis. And disease severity according to the Hohenir scale. And this scale divides the subject into 5 stages by the symptoms. And in our research, we only had symptoms class 2, 3, and 4. Participants were asked to self-assess the functionality status on the scale from 1 to 5, and 1 mean completely dependent, and 5 completely independent. Fatigue levels were measured using the fatigue severity scale, ranging from 9 to 63 points. And depression levels were assessed using the Beck Depression Inventory. So for our results, the median score of the fatigue severity scale was 44 points. Comparison between gender showed no significant differences in fatigue levels. No correlations were found between age, duration of the disease, or functional status, and fatigue levels. The severity of the disease did not significantly differentiate FSS score, nor did the severity of the depression. Conclusions. The subject exhibited a relatively high level of fatigue. Gender, age, duration of the disease, disease severity, and degree of the depression were not associated with the severity of fatigue. The significance of the fatigue issue warrants further research. Thank you.
Thank you for your presentation. I would like to invite you to ask a question for our presenter. We can start the discussion. We have any question for our presenter? What was I'm sorry. What is your own contribution of part from this presentation and this examination?
So together with my colleague, we did all the work. We did the questionnaire, we did the research, and we did the statistic together. We found the group of the people, and that's all.
Okay, so thank you a lot. We can finish the discussion.
Thank you.
The last one presentation will be evaluation of difference in angular values of spinal curvature in children group of Silesian agglomeration, presented by Marianna Strojna.
Szanowna Komisjo, szanowni studenci, nazywam się Marianna Strojna. Jestem studentką fizjoterapii 5. roku Śląskiego Uniwersytetu Medycznego i dziś przedstawię Państwu prezentację pod tytułem Evaluation of Differences in Angular Values of Spinal Curvatures in Children Group of Silesian Agglomeration. Prezentacja składa się ze wstępu, określenia celu badania, zastosowanych materiałów i metod, charakterystyki grupy badawczej, wyników oraz wniosku. Na wstępie należy wspomnieć, iż dzieciństwo to etap charakteryzujący się szybkim wzrostem i rozwojem kręgosłupa, który jest kluczowym elementem wpływającym na ogólny stan zdrowia i jakość życia. Zrozumienie mechanizmów tego wzrostu oraz czynników wpływających na jego przebieg jest kluczowe dla zapobiegania potencjalnym problemom zdrowotnym związanym z układem mięśniowo-szkieletowym w późniejszym życiu dziecka. Integralność strukturalna i funkcjonalność kręgosłupa w tym okresie mają znaczący wpływ na długoterminowe samopoczucie. Podkreśla to znaczenie kompleksowego zrozumienia dynamiki krzywisk kręgosłupa, zwłaszcza w odmiennym krajobrazie środowiskowym oraz społecznym aglomeracji śląskiej. Głównym celem była ocena różnic międzypłciowych w wartościach kątowych kifozy piersiowej i lordozy lędźwiowej w grupie dzieci aglomeracji śląskiej. Grupa dzieci została poddana testowi Adamsa w pozycji stojącej oraz dodatkowo w pozycji siedzącej, aby wykluczyć ewentualne błędy pomiaru. Do tego testu użyto skoliometr Banela. Wartość kifozy i lordozy, kifozy piersiowej i lordozy lędźwiowej zostały zbadane przy użyciu plurimetru Faurich-Steina. Każdy z uczestników podszedł do badania bez wierzchnej warstwy ubrań, aby możliwa była dodatkowa ocena subiektywna przed dokonaniem pomiarów. Do analizy rozkładu danych wykorzystano program Statistika StartSoft, w którym zbadano rozkład normalności testem Shapiro-Wilka. Poziom istotności statystycznej był równy 0,05, a do testowania hipotez wykorzystaliśmy test Umana-Whitneya, w którym mogliśmy porównać dwie zmienne. Charakterystyka grupy. Grupa badanych to 396 osób, w tym 196 kobiet, której średnia wieku wynosiła 12 lat oraz 200 mężczyzn, w której średnia wieku wynosiła 10 lat i oni zostali ostatecznie zakwalifikowani do badania. Badanie było przeprowadzone na Górnośląskim Centrum Zdrowia na Ochojcu w Katowicach. Grupa dzieci badanych była w wieku od 6 do 15 lat. Badanie było przeprowadzone w ramach pilotażowego programu stóp dzieci i młodzieży z Narodowego Funduszu Zdrowia. Program skupiał się początkowo rzeczywiście na badaniu stóp, natomiast nasi specjaliści z ponad 10-letnim doświadczeniem zauważyli z biegiem czasu, iż jest także obszerny problem dotyczący postawy ciała w grupie dzieci aglomeracji śląskiej. Analiza statystyczna wykazała, że w grupie dzieci aglomeracji śląskiej nie stwierdzono istotnie statystycznej zależności pomiędzy płcią a kątem kifozy piersiowej i kątem lordozy lędźwiowej. Poziom istotności w przypadku kifozy piersiowej wynosił 0,97, natomiast w przypadku lordozy lędźwiowej 0,68 w pozycji swobodnej. I tu na prezentacji widzimy po lewej stronie wykres ramka wąsy w odniesieniu dwóch zmiennych płeć i kifoza piersiowa, kąt kifozy piersiowej, natomiast po prawej stronie w odniesieniu do lordozy lędźwiowej. Kąt pomiaru rotacji tułowia w obu grupach jest taki sam. Wartości wśród kobiet i mężczyzn nie różnią się. Nie stwierdzono istotnego statystycznie związku między płcią a kątem rotacji tułowia. Dlatego na podstawie badań możemy wysnuć wniosek, iż w grupie dzieci aglomeracji śląskiej płeć nie determinuje wartości krzywisk kątowych kręgosłupa. Dziękuję za uwagę.
Thank you for your presentation. I would like to invite you to ask the question for our presenter. We can start the discussion. We have any question for our presenter? If no, what is your own contribution to this work? Jaki był wasz wkład w pracę nad tym materiałem? Tak. Dobrze. Nasz wkład był taki, że każdy z nas w danym tygodniu chodził właśnie do Górnośląskiego Centrum Zdrowia Dziecka i asystowaliśmy przy badaniach panu doktorowi Wnukowi, panu magistrowi Kroczkowi oraz pani doktor Szołtysek. Co prawda główne badania przeprowadzali właśnie nasi opiekuni, natomiast mieliśmy też swój w tym udział, że mogliśmy obserwować, spisywać te dane, no i później przeprowadzić odpowiednią statystykę. Dziękujemy bardzo. All the submitted papers have been presented. We congratulate all of the presenting authors and participants of the physiotherapy, orthopedic and traumatology session. At this point, I would like to ask the president of the jury for a few words to sum up the session.
I would like to thank all the participants and the study groups, valuable jury, and for your attendance for today's sessions, and organization, of course, committee for invitation for our session for today, physiotherapy and orthopedic session. And for the participants, I would like to say a few words that I hope that it will be first step in your scientific work and in your scientific journey. And during next year, or maybe 2 years, and during your life and the work, I hope that you will continue this work together to be sure that we can meet your results as very interesting for other scientists, and hopefully you will like to work as a scientific group and give us new results for that session for medicine and physiotherapy. Thank you very much for your attendance.
Dr. Renata Wilk, thank you a lot for these words. We truly appreciate your valuable comments, accurate observation, and work on presentation assessment. We would like to thank you. We we would like to dearly invite you for the decoration and closing ceremony of the SIMC 2024 conference, which will be held in Theatre Rialto on the 17th of May at 6 p.m. On the behalf of Student Scientific Associate, I would like to thank you all for participants in this session. You are heartfully invited to the workshop, which will be held at the CDISM on the Thursday and Friday. We would like to thank the prize for sponsor at our session, especially Enedu at MedCoach, who donate cash vouchers for online courses and webinars, as well as gift for the session winners. We sincerely thank you for being online with us on the physiotherapy, orthopedics, and traumatology session. Thank you a lot one more time, and I hope we can see you soon.